Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as the program facilitator and will present your questions to our panel of experts. This evening, Jefferson Health Heart and Vascular Specialists will discuss keys to heart health and solutions to common and complex heart and vascular diseases. Well, thank you so much for submitting your questions in advance of tonight. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer tablet, at the bottom of your screen, you'll see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And due to hospital, university guidelines and privacy, we are unable to comment on specific cases. Well, without further ado, I want to go ahead and introduce our experts for the evening, starting with Dr. Sanjay Kumar, vascular surgeon, and Dr. Raymond Singer, cardiac surgeon. Well, thank you both so much for joining us tonight. And before we dive into the questions, I'll give each of you a minute or two to just say hello and provide a little background information about yourself. So Dr. Kumar, let's go ahead and start with you. How are you doing this evening?
Great, I'm good. Thank you. Thank you for having me. It's a pleasure to be here. And yes, I'm a vascular surgeon. Essentially what that means is I deal with the plumbing of the body, essentially all the pipes in our body, the arteries. When arterial disease gets advanced, you tend to have problems from the arterial disease. And it's my job to either reroute the arteries or open them up. So in a nutshell.
All right, well, great. And thank you. I know we have an exciting discussion to get to tonight, but now let's turn to Dr. Singer. How are you doing this evening?
I'm doing very well, thank you. And thank you for having me here this evening and welcome everybody. I see we have a large number of people already online, so that's terrific. My name is Dr. Raymond Singer. I'm the chief of cardiac surgery at Jefferson Einstein Montgomery Hospital, part of Jefferson Health. We're located in East Norton, Pennsylvania, not too far away from Plymouth Whitemarsh and Bluebell, Collegeville, and King of Prussia. I've been a heart surgeon now for 32 years. I did my training at Jefferson, both in general surgery and cardiac surgery from 1984 to 1992, a long time ago. And for me, it's been a real homecoming. I spent a good part of my career at Lehigh Valley Hospital. And now the last 5 years, in fact, this Friday will be 5 years since I started here at Jefferson Einstein Montgomery Hospital. Now, Dr. Kumar says he takes care of all the vessels in the body. He doesn't take care of every single one of them. He's left the coronary arteries to me. So we do take care of the arteries in the heart.
All right. Well, thank you. And congrats on 5 years at Jefferson. Exciting.
Yes.
All right, let's dive into the questions because I know we have a lot to get to tonight. So question number one, a question we've definitely received a lot of. What is the difference between a cardiac surgeon and a vascular surgeon? So Dr. Kumar, we'll begin with you.
Excellent question. And Dr. Singer did allude to that earlier. The difference between a vascular surgeon and a cardiac surgeon is I deal with all the pipes outside of the heart, and even the main pipe coming out of the heart, the aorta, the first part of it, I don't deal with that either. So the job of a vascular surgeon is to manage blood vessels that are outside of the heart. We call them peripheral arteries or even the veins as well. And the procedures I offer as a vascular surgeon, which a cardiac surgeon usually does not offer, are angioplasty, stenting of the lower extremities or upper extremities, or the main pipe, the aorta in the abdomen or the belly for aortic aneurysm disease, and also carotid surgery, which is the arteries that feed blood to the brain. These are the two main pipes that go up into the brain. And if they get clogged up, yeah, it's my job to clean them out.
Okay, thank you. And Dr. Singer, anything you'd like to add there?
Yes, it is confusing to patients, and it was confusing to my own mother even when she talked about cardiology versus cardiac surgery. And particularly nowadays when there's a lot of overlap, because, for example, so I'm a cardiac surgeon, I'm a heart surgeon. I do procedures such as coronary artery bypass surgery, mitral valve repair surgeries. As Dr. Kumar said, sometimes there's aneurysms just near the heart that we operate on, and so on and so forth. But cardiologists who deal with the medical side of the heart also have interventional cardiologists who place stents. So if a patient comes in with a heart attack, they're likely to get a stent in a coronary artery. It's only when the blockages are either too extensive or, depending on their location, when they're recommended from the interventional cardiologist to the heart surgeon. So it can be very confusing for patients. Many patients will say to me, oh, my surgeon put in some stents. It was actually interventional cardiologist. And not to get more confusing, but then there's a whole other specialty known as interventional radiology. But there's a lot of overlap today, and that's really a good thing. And that's really a reflection of the fact that technology is expanding and becoming less invasive. But the short story is that as a heart surgeon, I deal with surgeries of the heart, open heart surgery, whether it's valve surgery, bypass surgery, atrial fibrillation surgery. And of course, as Dr. Kumar, he deals with not only peripheral vascular, but I suspect you also do abdominal vascular surgery too, with like.
Yes, that's correct. For blockages in the abdominal aorta, which is the main pipe that comes out of the heart that goes into the belly, or aneurysms of the aorta.
Right.
Yes, we do stents in there, or we do open surgery to replace the aorta.
Okay. Well, thank you both for those distinctions. And I think that's really helpful to ground our conversation today. So appreciate you detailing that. All right. So let's go ahead with our next question here. This one for you is, Dr. Kumar, this one's for you. Can cardiovascular disease be reversed?
So in general, it depends on what type of cardiovascular disease we're talking about. For the most part, if we're talking about atherosclerotic arterial disease, which can affect the heart, the blood flow going to the heart, or all the arteries that are in our body, in general, once you have plaque buildup inside these arteries, it is not reversible. But luckily, with modern technology and modern medicine, we do have ways to treat it, improve symptoms, and improve outcomes too, in terms of longevity and lifespan. So if there's a blockage in an artery, you can't per se reverse that blockage, which is the cardiovascular disease we're referring to, but you can treat it, whether that be with an angioplasty, which means ballooning the artery open, placing a stent there to keep it open. And if we can't do that, we offer bypass surgery to bypass the blockage. So just like on a highway, if the highway gets blocked, everybody takes a side road and gets back on the other side of the highway. So that's essentially a bypass. So you're creating a new circuit to get back on the highway later on down the road.
Okay, thank you. And I guess thinking through prevention here, what would be some ways one could help prevent cardiovascular disease?
So yeah, that's the key point right there is because cardiovascular disease, especially when we talk about atherosclerotic arterial disease, it's not reversible. So the key there is prevent it. And ways to prevent it are number one, exercise, diet, and the biggest risk factor known to this world is smoking. Smoking is the highest linked risk factor that can be modified to vascular disease, arterial disease, cardiovascular disease. A lot of different names for the same disease process, which can get confusing too.
Well, great. And that's why we're here to learn. So thank you. Okay, Dr. Singer, we will turn to you. Another question we received a lot is about BMI. So what is a healthy BMI for cardiovascular health? And can you first also just give an overview on what exactly BMI is?
Well, it stands for body mass index. And it's a calculation that takes into account your height and your weight. It's really that simple. And it comes up with a flow chart, and you probably have seen this in your family doctor's offices or your cardiologist's office. And they will put it into categories where 25 or less is the BMI. And by the way, you can go right onto Google and put in BMI, and you can calculate your BMI. All you have to do is put in your height and your weight. And the BMI of 25 or less is healthy. Now, there's actually a lower limit to that where you're unhealthy again if your BMI is too small. 25 to 30 would be considered overweight, and then over 30 we'd be considered obese. I think it's an important guide to do the things Dr. Kumar said when it comes to eating, exercise, and it is a way to track things because weight is not just a factor of how much you weigh, but it's also a factor of how tall you are. So your body surface area as it was. And I would just add to the conversation before about being unable to reverse cardiovascular disease. I would say we can, though, modulate it. And I know we're going to be talking a little later about medications and things like that. But you don't always have to believe, you don't always end up with surgery, whether it's vascular surgery or cardiac surgery, just because you may be having the diagnosis. I'm turning 66 next week, and at age 44, I was diagnosed with having hardening of the arteries. Why? Well, you can't pick your parents, and there are a lot of genetic reasons why I have it. And it's not uncommon to have somebody with a family history to develop in the 40s. But I've been on medications, and I've tried to live a healthy diet. And so far, knock on wood, I haven't need Dr. Kumar's help yet, or one of my partners in heart surgery. So I don't want patients to believe that, oh no, this is not reversible. There's nothing I can do. All is lost. Quite the contrary. And it's not just with surgeons, who you happen to be listening to two surgeons tonight. There are other things that you can do to slow down the disease process and maybe even reverse, at least in the heart. We talk about vulnerable plaque versus calcified plaque. And some of that vulnerable plaque can disappear with statin therapy, exercise, and so on.
Okay, great. Well, thank you. And I think continuing on this theme of prevention, Dr. Kumar, can you talk about what are the best ways to prevent heart attacks and strokes?
Yeah, excellent question. So in general, what I had mentioned earlier, the key ways to preventing development of cardiovascular disease, which can lead into heart attacks and strokes, is number one, being active. Daily exercise, or even daily walking, some kind of aerobic activity, has been shown over and over again to prevent cardiovascular complications such as heart attack or stroke. Aerobic activity is very important. And then there's diet, low-fat diet. Plenty of research has been done on cholesterol and its effect on our blood vessels. And when we talk about arterial disease isn't super selective, meaning that it's only going to affect your heart or it's only going to affect the arteries in your leg. It tends to affect pretty much every artery in your body at certain points. These are points that are more prone to arterial disease because there are weak points in the artery, or the hemodynamics in that artery are different, meaning how the blood flows. So there are certain areas we tend to get more arterial disease than others. So cholesterol plays a role. And low-fat diet is the key. If you control your cholesterol and you're on a low-fat diet, you're actually helping prevent arterial disease, because cholesterol is one of the main components of the plaque that builds up inside our vessels, and that eventually narrows down those vessels, leading to heart attack or stroke. So basically, cholesterol modification, diet, exercise, those are key things to preventing the complications of cardiovascular disease.
Sarah, if I may, I always talk to patients about the 3 E's: eating, exercise, and emotion. As surgeons, we like to keep things simple, 1, 2, 3. So 3 E's: eating, exercise, and emotion. And Dr. Kumar talked about this, but I think sometimes we make eating just a little too complicated. be honest with you. And I'm not a big fan of diets, much as Dr. Kumar said. It's really lifestyle changes that we're talking about. Mom was right. Breakfast is the most important meal of the day. Many of us tend to run out, not eat breakfast, and then we will eat our largest meal in the evening, and then lay down and go to sleep, which is extremely unhealthy to do. With exercise, it's some way every day. I call it the Dunkin' Donut phenomenon, or I guess now, what's the famous chicken place, Chick-fil-A? And you'll drive by these places and there's like literally 20 cars in line, and yet no one's at the counter. And you wonder why somebody just doesn't park, take a few steps, minimal exercise, but still a few steps, and go to the counter. Or when you're looking for that perfect parking spot at the King of Prussia Mall or at Wegmans, and why not just park as far as you can and take that extra moment to walk? Or when you're at work, try not to take the elevators. The old adage is, two down, one up. You should at least walk 1 or 2 flights of stairs a day at your place of work. And certainly we can do that at the hospital. And the last E is emotion. And quite frankly, it's the most important thing. But it's funny is as you change your lifestyle and you eat better and you sleep better and you drink more water and you exercise daily, your mental health will improve as well. And so it becomes this wonderful positive cycle, this 3 E's of eating, exercise, and emotion. So I think it's a nice way to put it in your minds, to categorize it that simply.
Absolutely. Yeah. Thank you for sharing that. I think I'll definitely keep that in mind, the 3 E's. Thank you. All right. Well, Dr. Singer, the next question here is for you as we continue our conversation. Can atrial fibrillation be cured or managed without medication or a surgical procedure?
Without medication or without a surgical procedure? Well,
Yes.
Atrial fibrillation is very common. And as a matter of fact, right before we started tonight, I got a text from one of the nurses I used to work with at my former institution. Her dad has atrial fibrillation, and they're considering an ablation. And a lot of people have heard about ablation. So first of all, what is atrial fibrillation? There are 4 chambers of the heart. We have the upper chambers, which are the atrium. And then we have the 2 lower pumping chambers, which are the ventricles. The ventricles is what really forces blood out. Sometimes people refer to the atrium as the collecting chambers, but they're important. They do contract. When you have a heartbeat, it's an electrical conduction that starts at what we call the sinoatrial node, and it's just above the atrium. And it sends the electricity in an amazing coordinated fashion. So you get that lub-dub. You have the atrium contract, and then the ventricle contracts. But sometimes, for a variety of reasons, the electricity doesn't go in a linear way. It starts going in circles. We call that reentrant circuits. And when that happens, the atrium gets confused and it doesn't beat in a single contraction beat. It looks like a bag of worms. And that's what atrial fibrillation is. And you lose about 10 to 20% of your heart function when you go into atrial fibrillation. That's why a lot of patients will feel lightheaded, dizzy, very tired. They might feel palpitations because when this happens, often the ventricle starts firing too quickly in response to the atrium not firing at all. And so atrial fibrillation is very common. The risk of atrial fibrillation is you lose some of your heart function, but the bigger risk is that when the bag of worms isn't beating as it should, the blood gets stagnant and you can form clots inside the heart, inside the atrium, particularly in this one portion of the atrium known as the atrial appendage. It's like a finger-like structure, and clots can form in there. And that can lead to strokes. We call that an embolic stroke. And that's why you'll hear, I think it's Kareem Abdul-Jabbar on the radio with the commercials for different types of treatments and blood thinners and the Watchman. So the first thing is, if you feel, and this is the most important thing, if you're walking up the stairs, you're doing some sort of exercise and you feel your heart racing, sometimes at night, whatever, please don't ignore it. You should go to your family doctor, see if you need to get a monitor, a heart monitor. I've had them before. Now they're just fit in your pocket. You wear them for a few days or a week, whatever your doctor wants. and they can see what kind of heart rhythm you have. Plus, in the office, they'll do an electrocardiogram. Most times, they'll treat you with what's known as a beta blocker, which is a type of medication. It's easy to take, and it just calms the heart down, slows it down, keeps it in rhythm. There are more advanced medications as well. One of the more common ones are amiodarone, flecainide. So medications are typically the first step, along with blood thinners. Now, people don't like to be on blood thinners, and people certainly don't want to stay in atrial fibrillation. So there are interventional procedures. The most common interventional procedure is done by what is known as an electrophysiology cardiologist, not a surgeon, a cardiologist who specializes in electricity. Sometimes we joke they're the electricians, we're the plumbers, as Dr. Kumar said. And so they take a catheter with the patient, just like you would in a cardiac catheterization lab, and they map out where these electrical channels are. And using radio frequency, they can actually ablate or create scar where that once circuit was. Why scar? Why would you want to put scar in the heart? Because interestingly, electricity doesn't go across scar. So if you can get the pattern where the circles are, and you can burn it, for a better word, and create a scar, then the patient will come back to normal rhythm. Sometimes the patient needs to be shocked back to rhythm. People have seen this on TV where they, charge paddles. It's done differently when you have atrial fibrillation, patients asleep and what have you. But the ablation is the first step. And there are surgical procedures for it. It's a procedure that I do known as the Cox-Maze 4. Dr. James Cox invented this procedure. Now it's much more invasive. It's not for every patient, but we do offer it at Jefferson. And it has 80 to 90% success rate. And then lastly, I'll say that there are two procedures to prevent stroke. One is done by the cardiologist. It's known as a Watchman. I think a lot of people have heard about this. And it's basically an umbrella that they sort of put up into the heart where that left atrial appendage is. And where that appendage is, they just fill it with this umbrella and it prevents clots from forming. As a surgeon, we work from the outside in. And so we put a clip across the appendage and we occlude it that way. When I do open heart surgery on most patients who are having heart surgery, they're at risk for developing atrial fibrillation, and we put that clip on the appendage. Once you have that clip on the appendage or the Watchman, even if you aren't able to get out of atrial fibrillation, you don't necessarily need to be on blood thinners anymore. So it's a great advantage for people because particularly you think about a lot of older patients develop atrial fibrillation. It may be from valvular heart disease, or maybe they had a heart attack or what have you. And, when you're 70, 75, 80, 85, to be on blood thinners, it's not easy and it's not fun. They bruise easily. You may need something else done. God forbid they fall. It's nice to be off a blood thinner. So getting out of atrial fibrillation is something you should strive for. Seek second opinions if need be, and understand that you may need a surgical procedure, but those surgical procedures are very safe and very effective these days.
Okay, thank you. And I know talking about these surgeries, at what point would you determine that a patient might need surgical intervention?
Now, for example, let's take coronary artery disease. There is an algorithm. And something I was going to say earlier when we were discussing the difference between a cardiologist, a cardiac surgeon, and then you have cardiologists or interventional cardiologists and electrophysiologists, and then you have, heart surgeons and you have vascular surgeons. At Jefferson, we have a cardiovascular institute, a department of cardiovascular science or medicine, however you want to say it. But what I want people to understand is that in today's world, particularly at Jefferson, we work as a collaborative team. And so the question is, when do you need to get to the next step? Well, the nice thing is we have meetings every week, sometimes every day, depending on what the status is. Obviously, it's an emergency. We get together. For example, we have what's known as a shock team. Sadly, sometimes people come in, they're in cardiogenic shock, and we have 4 or 5 people round the clock who can get on a Zoom call. Thank God for this technology. We can look at the films together and say, this patient should get medicines only. This next patient needs surgery. The next patient may need something more drastic like the artificial heart or transplant. And so it really is determined by a collaborative effort of the doctors working together. In the simple, not simple, but in the important case of coronary artery disease, initially we start with medications. And many times medications can mitigate the coronary disease. It may not reverse it, but it can keep a patient with a good quality of life. If they develop angina to the extent that it's at rest or when the minimal activity, or if unfortunately they have a heart attack, they'll be taken to the cardiac catheterization lab where a diagnostic study will give a map of the coronary arteries. And if it's able to be treated with a stent, we're all for that because that's something that can be done immediately. Yes, you will need to be on aspirin and other antiplatelets, most commonly Plavix. But if you can avoid surgery with a stent, we're all for it. But then the next level would be if someone has multi-vessel coronary artery disease, or they have blockages that are complex, calcified, or in locations that are just not readily amenable to stenting, such as the so-called left main, or the so-called widowmakers, which is the first portion of the left anterior descending coronary artery. In that instance, the interventional cardiologist will meet in a collaborative fashion with the surgeons, and they'll say, we'll get the call or day, hey, Ray, can you look at these films with me? It just happened today. And we looked at the films and we had a nice discussion as to what was best for this patient. And working as a team, we decided for that particular patient, we're recommending coronary artery bypass surgery. And so I'm going to be seeing him in the office Friday, and I'll be discussing what the team talked about and what our reasonings were.
Okay. Yeah, really interesting to hear that collaboration. So thank you.
Yeah.
Okay, so one last question for you, Dr. Singer, before I turn it back to Dr. Kumar. But a quick question here, looking for an explanation on the difference between premature atrial contractions, or PACs, and premature ventricular contractions, PVCs. How do they affect the heart?
Well, if you remember, I said there's the upper chambers and the lower chambers. The upper chambers are the atrium. Both the atrium and the ventricles, they're muscles. The atriums are a thinner layer of muscle, and they have electrical wiring going through it. You can't see it with the naked eye, but there's electrical wiring. It's very fancy wiring. It starts at the sinoatrial node, and then you have these fibers that go across the atrium to what's known as the atrioventricular node, and then you have wires that go down to the ventricle and allow for the contraction to occur in a coordinated fashion. Sometimes there's a little short. The electricity goes a little too quickly, or it skips off the normal track, and you get a contraction that's not at the right time. So instead of that lub dub, you'll get lub 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 dub. There's that extra beat or two up top, and that would be a PAC, or premature atrial contraction. The concern about PACs is that guess what they lead to often? Atrial fibrillation, because what you're seeing is the start of these aberrant reentrant circuits, and you're getting a few extra beats. So I'm always a little bit more concerned about PACs because that could readily lead to atrial fibrillation, which is harder to treat, but important to get reversed. PVCs, premature ventricular beats, I think most of us have some of them, and they're normally very benign. They can be made worse by a lack of exercise, too much coffee, too much of those Monster drinks and Red Bulls and Celsius drinks that are out there, which are full of caffeine and other things. Chocolate, I don't know. People always say that. I've never really seen any science on that, but something I don't know. I would rather give up the Red Bull than give up chocolate. But PVCs by themselves, if you have a few every minute or so, they're annoying, and you can feel your heart have that extra beat, but they're usually benign and don't really mean anything. That said, if you have a lot of them, it's like anything else. It could be a problem with the wiring. It could be evidence that there's what we call ischemia, or a lack of blood supply that could be a heart attack pending. So my recommendation, like always, to patients are, if you're feeling a fluttering in your neck, if you're feeling a fluttering in your chest, particularly if that feeling of palpitations is associated with shortness of breath, dizziness, or chest pain, then you absolutely need to seek medical attention right away. I'm a big supporter of going to your PCP. We all know that sometimes you call cardiologist's office, unless it's life and death emergency, you may not get an appointment for months. It's everywhere. We try to get patients in quickly, but your PCP is usually there all the time for you. And if you need to be seen, then your PCP will make the call to the cardiologist and get you in that much sooner. And or even go straight to the emergency room if you're really feeling ill. But that would be my biggest message is most times a few beats here or there, you're walking up the stairs, you had a little too much coffee, you're a little tired, perfectly benign. But if it's associated with symptoms such as, dizziness, certainly blacking out, chest discomfort, then you need to seek medical attention right away.
Okay, thank you. Yeah, definitely an important reminder to not ignore those symptoms. Okay, well, Dr. Kumar, we will turn to you now. No, previously we're talking a little bit about that genetic component. So can someone overcome hereditary risk factors for heart disease?
Yes, for the most part, they are modifiable. We have new medicines now. So the biggest genetic predisposition to heart disease or coronary artery disease and even atherosclerosis is familial hypercholesterolemia. What that means is it runs in the family. You have very high cholesterol levels, and some of these patients, if they go unchecked or you don't diagnose them late enough, they can have cardiovascular complications at a younger age. We see heart attacks nowadays, patients in their 40s and even early 50s. And I've actually most recently seen patients with a heart attack even in their late 30s. And you check their cholesterol level, it comes back, it's through the roof. So cholesterol in itself is a risk factor for complications of cardiovascular disease, advancement of cardiovascular disease, and the familial component of that, where it's passed down from parents to children, it can be treated. We have very aggressive cholesterol medications now that can bring those cholesterol levels promptly down. And your medical doctor, your cardiologist, they all have set targets where your cholesterol should be. Just to mention, a new drug that's on the market now is Repatha, and we're seeing remarkable reductions in even the highest cholesterol levels in patients, and they get them down to below 70, which is quite remarkable. So yeah, that's a very modifiable risk factor, and this is why even in pediatrics, there are more and more proposing that cholesterol should be checked as soon as a patient turns 18, just to look for those kind of risk factors. That's your first lab test and your first clue that what's your cardiovascular risk.
All right, well, thank you. And exciting to hear the progress, but also another important reminder to get tested. So thank you.
Yeah, definitely go for your checkups.
Yeah.
Very important.
Okay. All right, Dr. Singer, turning back to you now, can you talk a little bit about the benefits versus risks for taking statins for lowering cholesterol?
Well, I'm a big fan of statins. I have personally been on statins since I was 44 years old. So that's 22 years now I've been on statins. I don't have any, disclosures with any of these companies. So I don't want people to get the wrong idea on that. I was started on Lipitor, which is one of the more common ones. It's an excellent drug. I did have some problems with muscle pain, and I switched to another one known as Crestor, and I've been stable on that. I think that the benefit of these medications are that they lower your cholesterol, and they lower the risk of vulnerable plaque that I mentioned earlier, the soft plaque, not the calcified plaque that we can do nothing about, but it reduces the vulnerable plaque, which is quite frankly what causes the heart attacks. But there's another benefit to statins, and that is that they have a strong anti-inflammatory role. And we believe that part of the cause of heart attacks are ulcerated plaques that rupture due to inflammation. And so we believe that statins not only reduce the vulnerable plaque, but they stabilize the plaques so that they don't break off and thrombose. Now, the downside is that, of course, no one likes to take medications. You have to take it every day, usually. Some people do get muscle discomfort. There were some concerns, certainly not proven. In fact, there are studies that show just the opposite of maybe early forgetfulness or dementia as a result of statins. But then other articles came out and said it might even be beneficial. I don't think the word is out on that. I personally feel that the benefits of statins outweigh the risk.
Okay.
I think it should be in the water like fluoride, if you want to know the truth.
Yeah, I agree 100%. The amount of reduction in complications of cardiovascular disease that we've seen with the use of statins is remarkable over the years. So yeah, it's a very important drug to be on if you do get diagnosed with high cholesterol, or even, obviously arterial disease, coronary artery disease. The other aspect, even, there's data with reduction in strokes also with the use of statins. So anytime I see a patient with arteries that are, going up to the brain, the carotid arteries with carotid stenosis, well, that's one of the first things we make sure is that they're on a maximized dose of their statin, because it's clearly been shown to reduce strokes. Even aneurysmal disease, aortic aneurysms, especially in the belly that I treat, they have also been shown to actually reduce the growth of these aneurysms. So we have criteria when we fix these aneurysms, and to put it in layman's terms, an aneurysm is a bulging of the pipe. So basically, if you think about a hose and it bulges out at one area because the wall is weak, if it bulges too much, obviously it's going to pop, and that's a life-threatening problem. Statins have been shown to even reduce the rate of growth of these so that it doesn't grow to a point where you need major surgery to have it fixed. So yeah, I agree 100% with Dr. Singer. The benefits definitely far outweigh the whatever little complications that are being reported in the literature.
Sarah, I noticed, if I may, a couple of people asked some good questions. Can I address them?
Yeah,
So one of our attendees, Mary, she asked, so does vulnerable plaque get dissolved with the right statin? And we just answered, it does. But then she asked a good question. How do you know? How do you know? So I'll just tell you what my regimen is. I get a full physical exam by my PCP once a year, and I see my cardiologist once a year. With my cardiologist, every other year, I get an echocardiogram to see that my heart functions okay. I get an electrocardiogram to make sure there hasn't been any change in my rhythms. And I will get a stress test. Now, a stress test that we offer that's very good is known as a PET scans type of stress test. People have heard of PET scans with other types of diagnoses, but it works for the heart as well. And so there are studies that we call surveillance studies that can tell you if you're doing well from that standpoint. The other question I really like here from an anonymous person, one of the attendees, what is the most beneficial exercise for vascular health? I'd love to hear Dr. Kumar's answer that. From a heart standpoint, the most beneficial exercise is walking every day. And particularly as we get older, look, we're not going to be hitting the streets running 10 miles. Some people do. God bless them that they are able to. But I'm very big on low impact aerobics, like using an elliptical machine, a bike, a stationary bike. But I think going back to the 3 E's, eating, exercise, and motion, to really help your emotional health, your mental health, I think walking every day for 30 minutes is the best exercise. It increases endorphins. It makes you feel better. It allows your mind to clear. It's nice to get outside. I don't know, Dr. Kumar, what do you think about the best exercise for cardiovascular health?
Yeah, I agree with you 100%. Walking at a steady pace for 30 minutes a day has been over and over shown to improve a lot of the things you mentioned, mentation. And there's even articles coming out about how dementia is delayed or prevented when you do 30 minutes of, or any kind of daily walking at a steady pace. The benefits, it pretty much benefits everything. The lung reserves, especially if you're a smoker, it improves lung reserve, breathing, and going back to the old days of surgery, how we used to assess if a patient could tolerate a major operation was if they could do a flight of stairs, they didn't need any kind of cardiac clearance or anesthesia evaluation before the surgery. I would say if you can do a flight of stairs, you're going to sail through any major surgery. And it applies to this day. We have all these fancy tests, but bottom line, I ask every patient, can you do a flight of stairs? And if the answer is yes, I tell them, you have a 99% chance you're going to do great with this surgery. So don't worry about it.
I think
All right.
I'm sorry.
No, go ahead.
Another excellent question here from one of our listeners. Kevin mentioned that he had a stent in 2017 for an LAD blockage. His stent started to scar and closed 18 months later. Basically, the question is, why do stents close and why do bypass grafts close? And it really depends on a number of factors, including how complex was the blockage to begin with. A patient who is diabetic, for example, may not do as well with stents over the long term compared to bypass surgery. When it comes to bypass surgery, when we make the new conduits, when we do the bypasses, we try to use arteries as much as possible, as opposed to the vein from the legs. Many people may remember the days where there were incisions all the way up and down like a zipper on the leg. And now when we do harvest vein from the leg, it's usually through a tiny incision and a telescope. But what we like to use more often than not in the chest are arterial grafts, which tend to stay open a lot longer, even in patients who are diabetics. There's arteries in the chest known as the internal mammary arteries. We can actually harvest an artery from the arm. Sure, Dr. Kumar probably doesn't like us to take out arteries that he may need, but we do use them in the heart. And arterial grafting, which is something we specialize at Jefferson in, allows the new bypasses to stay open much longer. Now, if you're not diabetic and the area that was stented was a very discrete area, that stent may very well stay open the rest of your life. And the other thing is, once you have a stent or you have bypass surgery, that's only part of the solution. The rest of it is up to you. And that means the lifestyle changes that we talked about tonight. It means taking statins, aspirin, Plavix, or whatever your doctor recommends, walking every day, and focusing on your mental health too, because there's no doubt that stress, and there's plenty of that in this world today, affects your entire body, but certainly your cardiovascular system. In fact, there's an entity known as stress-induced cardiomyopathy. The fancy term is Takotsubo syndrome. It was named in 1991 by the Japanese. A Takotsubo is an octopus trap. It has a narrow neck and a big bowl. And that's what the heart looks like when under extreme stress. It balloons out. At one time they call it ballooning there, but the technical term is stress-induced cardiomyopathy. And it gives real credence to the phrases, she died of a broken heart, he was scared to death. The point is that what we're trying to say with all this is that it's really not just the doctor, it's all of us together. And that all of us together is, and the old saying, doctor, heal thyself. I need to do the same thing when we get done tonight. I'm now motivated to go take a walk. We need to do the lifestyle changes, exercise daily, focus on your mental health, and see your PCP and your cardiologist on a regular basis.
Absolutely. Going back to those 3 E's. So thank you.
Eating, exercise, and emotion.
Yeah. Yeah. Well, thank you. And know that we've been receiving a lot of great questions in the chat. So thanks for taking the time to address a few of those. I'll go ahead and just ask a few more of our submitted questions, and then think we can turn to the live chat for the rest of the evening, knowing we're having so many great questions come in. So thank you, audience members, for your participation. We really appreciate it. Okay, Dr. Kumar, I will turn to you for just one question here. If you could talk a little bit about atherosclerosis, are there any ways to prevent it?
Yes, definitely ways to prevent it. First of all, atherosclerosis is the hardening of the pipes. Essentially, plaque buildup in our arteries that leads to heart attack, stroke, or for me, for patients that I see, a lot of times they present with non-healing wounds to the feet or a symptom known as claudication, which is the earliest sign of atherosclerosis. And interestingly, claudication is one of the first indicators of a high chance that you probably have coronary artery disease as well. And historically, the ABI, which is a measure of how much blood flow is getting to your feet, it's a ratio of your blood pressure in your arm to the ratio to your ankle. That's a indicator not for identifying vascular disease in the legs, which it does do, but it's also a predictor of whether a patient is developing coronary artery disease. There's been a high correlation, and that's why a lot of cardiologists will do ABIs, or historically would do ABIs in their office to see what the risk would be for a patient to have coronary artery disease as well. So getting back to your original question, is atherosclerosis preventable? Absolutely. And if you get diagnosed with atherosclerosis, you want to not only just prevent worsening of it, but you also want to prevent its complications. We talked about atherosclerosis creates plaques, and there's different kinds of plaques. There's soft plaques, hard plaques, which is calcium in the plaques, and then the plaques can rupture, just like in the coronaries. They can also rupture in the arteries of your legs and go down into your feet and cause a very bad problem known as gangrene, like gangrene of the toes and things like that. So for prevention, exercise, diet, low cholesterol, and making sure you're on a statin medication if your doctor says you should be on one is the best way to prevent atherosclerosis. And as we mentioned earlier, atherosclerosis can affect any artery in the body, in the brain, in the neck, where the carotid arteries are, which are risk factors for stroke, obviously the coronaries, which are the arteries that feed blood to the heart, causing heart attacks. And then for me, the patients that I see, arteries in the legs, causing problems in the legs. Non-healing wounds, painful feet that are turning red, gangrene. These are all problems with atherosclerosis for the arteries in the leg. Oh, I wanted to touch back on claudication. That's the first symptom we see with patients that are developing atherosclerosis of the legs. Claudication, or to claudicate, means to limp. So basically what happens is, as you're developing a blockage in one of the main pipes of the legs, blood flow to the calf muscle decreases when you're trying to walk. Whenever we walk, our muscles need more blood flow, but because there's a blockage or narrowing developing in one of our pipes, that increased demand for blood flow cannot be met. So the calf starts to hurt. That's the claudication pain. And patients will immediately rest. Rest within 5 to 10 minutes, relieves the pain because the muscle relaxes, and then you're able to walk again. So that's one of the first symptoms we look for in patients with atherosclerotic arterial disease. And
Okay.
it is manageable. I don't know if you want me to talk about managing claudication, but yeah, that's easily manageable. Nowadays, the first line of therapy is always exercise therapy. So in other words, I tell my patients, if you have claudication, you want to walk through that pain, push it. It's no pain, no gain in that situation. And the further you can push it into that pain, the muscle adapts, you build collateral flow, and you can actually overcome that pain and avoid a major vascular procedure to treat your claudication.
Okay, thank you. Thank you. And continuing again on this theme that we've been discussing of prevention, another question we have for you, Dr. Kumar, can heart health be improved just with diet and exercise alone? Is that possible?
Yes, I think, we see plenty of patients that get just screening ultrasounds. There's plenty of programs out there that will screen all your arteries in your body, and then they identify that you've got plaque building up in your arteries. It's not to a point where it's causing any problems, not causing any blockage, not causing any decrease in flow, but we can see plaque development in our arteries as early as the age of 18. And if your cholesterol is okay, your doctor will recommend, you should probably start exercising. More aerobic exercise that you do will help prevent these plaques from getting worse. You want to make sure your blood pressure is well controlled, because blood pressure is one of those things that causes stress on the wall of our arteries. That stress disrupts this very thin layer we have lining our pipes, essentially. And when that layer gets disrupted, plaque builds faster. So we want to make sure our blood pressure is well controlled so we don't get that shear stress on our wall to start generating the plaque. So yes, exercise can definitely prevent atherosclerosis.
Okay, great. Well, thank you. All right. And Dr. Singer, coming back to you here, our last question before we'll just spend the rest of the evening diving into our live questions. At what age should one start seeing a cardiologist?
Well, I guess it depends on your family history first and foremost. So if you do have a family history, a brother, a sister, a mother, a father, perhaps a grandparent who had heart disease, then I would say 40, if not even 35, but certainly by the age of 40. Now, if there is no family history or otherwise healthy, as I said before, I'm a big proponent of seeing your PCP on a yearly basis. PCPs can do a lot of evaluation, and they know you the best. You know, as I said, I see mine, Dr. Chris Drum, every single year. And then when other things come up during the year, but I get a full physical exam every year. And that'll include his ordering tests, whether it's electrocardiogram. For example, in my family, carotid artery disease is another one that is very familiar with Dr. Kumar and also something that runs in my family. So I get, in fact, I have it coming up. Every 2 years or so, I get that done, but that was ordered by my PCP. I think going to both of them is important, but I think if there's a family history as early as age 40, you should go, if not age 35. I don't think there's a set rule. Dr. Kumar, what do you think? I'm curious.
Yes, I agree. You know, the main concept here is that start with the PCP, right? They will guide you. They have all the preventive guidelines that they run through with you when they see you. As you can attest to, Dr. Singer has already said that. Basically, you know, making sure you're in touch with your PCP, getting your regular exams, and if the PCP feels you have a strong history of coronary artery disease or your cholesterol is difficult to manage, they will refer you to the cardiologist. I don't think there's an exact rule that you have to see a cardiologist by a certain age, but definitely have to see your PCP on a regular basis.
Yeah. And I think the biggest message all, and I hope this is a big takeaway, and when we think back at COVID, this was a problem. If you're not sure, like I saw one of the questions, we're going to get into the questions, was can you tell the difference between muscle pain and heart pain? Look, I think most of us have a sense of what our bodies are doing. And I think that if you are not sure, if your exercise tolerance is decreased, if you feel like you're getting dizzy, if you're feeling something funny in your chest, the most important takeaway message is seek attention. Go to your PCP and get evaluated right away. And if need be, your PCP will do the step up to the specialist that you may need, whether it's a vascular surgeon, electrophysiologist, cardiologist, cardiac surgeon, what have you. But don't think it'll just go away. I can't tell you how many times patients get in trouble because they just, oh no, I don't think it's anything. I'm going to be okay. There's no family history. I'm okay until they're not okay. And then it's really can be sadly a crisis. So to me, that's the most important message.
Sorry to interrupt, but that's an excellent point. I think a lot of people out there say, oh, it's just aging, and you know, they blame it on that, and then they don't seek attention.
Right.
So, you know, it's not
and it's
always
understandable. I mean, it's understandable. Nobody wants to go to doctors if they don't have to, or to the hospital. And when I mentioned COVID, sadly, people were literally afraid of going to the doctor or to the hospital because we didn't really understand COVID that well. And in the early days, and you know, you were afraid if you went, you would catch it at the hospital. And sadly, there were patients who had heart attacks at home that might have Now, there are always positive things from this. I think COVID did make us think about our health a little more. It allowed us to do telemedicine. Jefferson is leading the country in telemedicine technology so that you don't necessarily have to come physically to the hospital for certain checkups and follow-ups and what have you. But the reality is, if you're not sure, if there's something going on, please don't be a denier. It's better to go get checked out and find out everything's okay, and then have a baseline to go on to compare with as you go on in your life.
Absolutely. So everyone go to your primary care physician if that's a takeaway from tonight. Okay. All right. So I think with that, let's go ahead and turn to the live questions. Like I said, we're receiving a ton, so we have a lot to get to. For the first question here, it's a little bit more specific. Dr. Singer, I will turn to you for this one. This person says, I recently had an ECG performed and would like to know what the results that read possible left atrial enlargement, poor R wave progression mean. This person wonders if they should be worried.
Yeah. So left atrial enlargement, what that means is that that portion of the heart is expanding, it's becoming dilated. So for whatever reason, it's seeing an increase in pressure inside the heart, increase in blood pressure. That can be from atrial fibrillation. I don't know if the patient has atrial fibrillation, but that would be a very common reason for atrial enlargement. What's interesting about that EKG is they said poor R wave progression. That could mean that there is some scar on the pumping chamber of the heart. When patients have coronary artery disease, they develop scar. If it's very serious, that's a heart attack. And so with the scar, the electricity isn't as high, so it's the R wave progression. It's smaller than it should be. It should be nice up and down, and it's not quite getting up, and it might be because the electricity isn't passing through the muscle as well. So for that patient, they clearly should have an echocardiogram and a stress test. We don't want to give out specific advice on meetings like this, but the common sense thing, as we've said all night, is seek attention. Now, obviously, their doctor did the EKG, and the most important thing is if you feel you haven't gotten the answers, ask that very question to the doctor. And we always say at Jefferson, if you're not sure, please get a second opinion. I think one of the things we're very fortunate at Jefferson is we see a lot of patients who want second opinions, because sometimes things aren't explained as well as they should be.
Absolutely. Advocating for yourself. Okay. All right. Next question here. Dr. Kumar, I'll turn to you for this one. Is it possible to clean out the arteries?
Yes. There are many ways to clean out arteries. One of the procedures that I do is called atherectomy. What that means is essentially you're drilling through the artery and coring out the plaque and removing it. It's a little bit of an involved procedure. It does have risks. However, it does a good job when you need it done to clean out the artery. You have to be careful with this procedure. A lot of private centers out there are offering it, but doesn't mean just because it's available and you have plaque buildup in your artery that you should get this procedure done, because it can have complications. And let's say you're going there for a small amount of plaque and they start drilling through this plaque, the plaque ruptures, it travels down the artery and can actually destroy parts of your foot. Blood flow can be cut off to your toes, gangrene can set in. So it is a very, very specific procedure for, certain set indications. You don't want to be using it on every artery. You don't want to be using it on everyone, obviously. I reserve it personally for patients that are so advanced in their vascular disease and their arterial disease of their leg that they're about to lose their foot anyway, because the blood flow to that foot is so poor. I have to do everything I can to restore blood flow to that foot. And atherectomy is, in that situation, an excellent procedure. But in patients that have less arterial disease burden, I don't usually recommend it. There are simpler ways of opening up arteries, and we mentioned those earlier, angioplasty and stenting. Those are less riskier. But bottom line, it's case by case, and it's very specific to a certain pattern of disease.
Absolutely, yeah. I mean, and again, a lot of these questions are a little bit more specific, but definitely we're answering this overarching. So thank you. All right, and on that note, Dr. Singer, a question for you. In 2006, this person says, I had quintuple coronary artery bypass graft surgery. In 2014, one of the grafts collapsed and I needed a stent put in. What can cause a collapse like that?
Yeah. Well, just like with stents, and we mentioned this earlier, you can have further buildup of plaque, just like you have in your native vessel. Just because we do a bypass doesn't mean that that bypass isn't susceptible to the same factors that caused blockages in the first place: genetics, diabetes, high cholesterol. And that's why it's very important after you get a stent or bypasses to really have this behavior modification, these 3 E's of exercise, eating, exercise, and emotion. Now, having said that, we've come a long way. And that patient said 2014 is when it clogged up. So, as I mentioned earlier, one of the things we do at Jefferson Einstein Montgomery Hospital and throughout Jefferson Health System, we have 5 heart surgery programs right now, is we use more and more arterial grafting. It sounds like that was a vein graft that occluded. And the reason we use the arterial grafting is it's much less common for an arterial graft to occlude over time. Unfortunately, this can happen, but we're seeing, as we've advanced the technology, we're seeing less and less closures. In fact, it's an interesting point. When I was training many, many years ago, repeat coronary bypass surgery was a very common operation. Now, this is before stents and everything. It was one of the more common operations we do. I think in the last 15 years, I think I may have done just one. And that's because of statins and aspirin, Plavix, lifestyle changes, these other more fancy medications that are out there, and quite frankly, the technology of the stents. Thank God this patient had that bypass reopened due to stenting. So we rarely do a second time coronary bypass operation. So one of the biggest changes over my 30-some-year career.
Oh, that's
Yeah,
interesting.
and one thing to remember about bypass failures, I mean, even when I do bypasses in the legs, a lot of times they fail because of certain risk factors that haven't been modified. The number one risk factor for bypass failure is smoking. So despite being on statin medication, an antiplatelet, or a blood thinner, these bypasses still fail, unfortunately. And the number one risk factor that we've identified is smoking. So making sure that you're not smoking after your bypass or even your stent is very important.
And Dr. Kumar, would you agree with me that vaping and the use of, some of the marijuana out there that is smoked is just as bad as smoking cigarettes?
Well, I mean, I don't think it's just as bad. I actually counsel a lot of my patients to quit smoking and try vaping instead. The number of traumatic components or toxic components that are in cigarette smoke compared to vaping, it's a very big difference. So I would rather have a patient try to, come off of smoking and do vaping for a while, and then, keep going back and forth. They try to quit smoking and then it only lasts for a month and they're back on it. Vaping, it's not pure smoke like what you get from a cigarette. And we've identified in the cigarette that there's there's literally tens of thousands of toxins in there that are harmful to our blood vessels. Plus we have nicotine. The effect of nicotine on our blood vessels has been proven over and over again by research, that it depletes a certain messenger that the cells need to work inside your blood vessel. That messenger is depleted and it leads to atherosclerosis, vasoconstriction, which means the arteries actually contract and shrink. So cigarette smoking is definitely worse than vaping. Obviously, vaping, I'm not promoting vaping. I'm not saying you should be vaping. Vaping also has its set of problems. But if I want a patient to quit smoking, especially if I've done a bypass on them, I recommend vaping. And I've had a lot of patients that switch to vaping and then eventually come off of that as well. So it is the lesser of two evils, but let's not say that it's okay.
Yeah.
Okay. All right. Well, thank you both. All right. Next question here. Dr. Singer, this one is for you. This person is wondering, what is a PFO and what's considered small or large? Can a PFO cause an arrhythmia? How common is a PFO and how complicated is it to repair?
So PFO stands for patent foramen ovale. When we are embryos, when we're in mom, we aren't using our lungs. And so there's no reason for the blood to go from the right atrium to the right ventricle and then to the lungs. So there is a connection between the right atrium and the left atrium. It's an opening, it's a hole known as the fossa ovalis. And it really comes about as two flaps. Showing it like this, two flaps, and the blood goes through there while mom is taking care of your oxygen. And then what happens is you breathe, you're born, and you take a deep breath, and the high pressure in that compacted lung now expands, and the pressure drops, and so blood now, the pressure changes in the chamber, and instead of going through, the chamber collapses on itself. And it seals over time. But in about 20% of us, despite all that working out the way it's supposed to, it never seals. So it's patent. There's a patent frame of ovale, and blood can still slip through. Now, what's interesting about that, for the most part, the pressure on the opposite side, the left side of the heart, is such that even though it's not sealed, it keeps it shut. But if you strain and you increase the pressure on your right side, like you cough, it can reopen it. And it can lead to an entity known as paroxysmal embolization. And what that means is that, let's say you had a little clot in your leg or something, and you coughed or you strained, and just at that moment, that clot goes up into the heart, it could cross over. Instead of going to the lungs, it can cause a stroke. There was a middle linebacker for the Patriots, Bruschi, I believe his name was. And he had a slight bruise or injury to his leg, and he ended up with a stroke. He didn't realize why, and it turns out he had a patent foramen ovale. So these are openings or holes in the atrium. Now, 20% of us have it and don't even know it. Should we all run out and get tested? No, because really 90-something% of the time, they're asymptomatic. You live your entire life, you don't know. Obviously, if you have a clot, this paradoxical embolization, then you need to have it fixed. Other reasons to have it fixed, as you alluded to, is sometimes it's not just like this, it's like this. There's really a significant hole, and we call that an atrial septal defect. And in those instances, normally we recommend that they get fixed. Good news is you don't necessarily need open heart surgery to have a hole in your heart fixed these days. There's a device known as the Amplatzer device, and an interventional cardiologist can stick, it looks like a little bit like a mushroom, and can stick between it and bring the layers together and seal it. And so in patients who are symptomatic from a PFO and are relatively small, less than, I believe it's 4 millimeters, they can have it closed with the Amplatzer device. If they do have a true atrial septal defect that needs to be closed surgically, we can do that with minimally invasive procedures too, smaller incisions, and the recovery time can be much quicker.
Okay. All right. Well, thank you.
It's a little confusing. I hope I didn't confuse people too much, but.
No, really helpful to hear that you walking us through that. So appreciate that. All right, we will move on to our next question. Thank you again. I know we have questions still coming through, so we appreciate the interaction. So for this next question, either of you feel free to chime in. Are there stents that are less likely to be rejected by the body? This person says, I had a medicated stent placed in 2017 on the left anterior descending artery with a 95% blockage. After 18 months, it started to scar and close. So later I needed bypass surgery and I was informed the stent was rejected. Anyone want to comment?
Well, it's not so much that it's being rejected, like when we think about transplants, getting rejected. Anytime you put a foreign body into the body, I mean, the body's natural reaction is to scar, and scarring causes closure. And so the idea of a medicated stent, these are medicated stents that are basically like chemotherapy type of thing that decreases minuscule amounts of medicine and that decreases the amount of inflammation and reduces the amount of scarring. They've come up with other ideas, such as endovascular stents that are actually biologic in nature. There was just a recent study. Unfortunately, it has yet to come to prime time yet, but there's been research on this ever since I was in training, where the stents are basically lined with your own cells, and then those cells would become, and then it wouldn't scar down. But these are, again, the factors that will lead to scarring would be, again, diabetes, smoking, and honestly, a little bit of bad luck. I mean, if you have a very strong genetic predisposition towards scarring, you will be more likely to have a stent go down. Good news is, in her case, she was able to get probably an arterial graft, the left internal mammary artery, to the left anterior descending coronary artery. And the results of them are almost a lifelong warranty. Really, the studies are 96, 97% of those are patent at 20, 25 years. So I think she's going to be in good shape.
All right. Next question here, we'll move on. This one is about statins. So I know we were talking about this earlier. Is Nexletol as effective as statins? Does it have anti-inflammatory properties? This person says, I'm interested because I couldn't tolerate statins.
Well, yeah, I probably a better question for a cardiologist than either a vascular surgeon or a cardiac surgeon. I would say that there are a lot of alternatives. I did look at some of the questions. Similarly, somebody asked about red yeast. Always have trouble saying that together. Say that 5 times quickly, red yeast. So are they as effective? I mean, these would really, to answer the question, really be at a level of understanding the meta-analyses in large series. But the short answer is that there are other medications that can reduce the risk in a similar fashion to statins. I couldn't sit here as a surgeon and tell you the science between each of them individually. But I do, as I said earlier, I am a fan of statins. Now, the question I would have for this person is whether or not they chose other statins. I mean, there are other choices with statins. So if they have a problem with one, like I had a problem with Lipitor, and then I was successful on Crestor.
Okay, yeah, helpful to keep in mind there. All right, next question here, Dr. Kumar, we will turn back to you. What is the difference between calcified arteries and those with plaque?
So plaque is the broad term, and it encompasses calcified arteries too. So plaque just means that something is building up inside the wall of the artery. And if it builds up too much, it can become calcified. And then it starts to narrow down the lumen or the wherever the foramen of the artery is and causes a blockage. So calcium is just a type of plaque. We mentioned earlier that there's soft plaques and then there's calcified plaques. Calcified plaques are late stage. So essentially all plaques in the beginning are soft. And as the scarring process in the blood vessel ensues, there's an immune response, an inflammatory response. The body reacts to the plaque in the wall by this immune response and an inflammatory response. And essentially, over time, it becomes calcified because calcium is a byproduct of long-standing inflammation. And this leads into why anti-inflammatories such as aspirin and even the anti-inflammatory effect of statin is also so important in reducing the progression or the rate of progression of atherosclerosis and plaque development. So the basic best medical therapy regimen that we talk about when we treat plaques or atherosclerosis is always aspirin, a statin, and maybe a second agent as well, depending on how much risk factors you have and what other problems you've had in the past.
Okay. All right. Well, thank you. Next question here. Dr. Singer, we'll turn to you for this one. This person says, I have coronary artery disease and have developed a raspy voice. Is there any relation to my heart disease potentially causing this?
You know, I saw that question and I was hoping you wouldn't ask me because
Sorry.
I don't think so. I don't know, Dr. Kumar, do you have any guess on that? I mean, you can have a raspy voice after heart surgery, but this person was just saying that they have coronary artery disease. They haven't had surgery, is the way I read the question. After surgery, because of the breathing tube that's put in, you can get changes to your vocal cords. And whenever you have surgery in the chest, there are nerves that affect in the neck and in the chest, the vocal cords, and that can be a problem. Unless, Dr. Kumar, the carotid disease.
No, usually carotid, I mean, same as you, unless you operate on the carotid, you usually don't get a raspy voice related to heart disease or even carotid disease. Yes, as you said, there are nerves even along the carotid arteries. So when we do carotid surgery, we're very careful to move those nerves out of the way, because one of the complications of carotid surgery and even open heart surgery is injuring a nerve that goes to the vocal cords. And that can cause a raspy or hoarseness of voice. But
yeah,
and
but keeping with the theme of tonight, though, if someone, I know the ENT doctors would agree with this, if you have a change in your voice, you need to be seen by your PCP. And I would start with a simple chest X-ray, because you can be something very benign, but you know, there could be something pushing on the nerves that causes the hoarse voice. So I would, like all the other themes tonight, I would not just say, well, I've got a raspy voice, I'll deal with it. Really should seek attention. There are a whole host of things that can cause that.
yeah, that's an excellent point. Yep.
Yep. Not ignoring symptoms. So, okay. Thank you. All right. Next question for either of you. Feel free to chime in. How important is lipoprotein in evaluating heart risk?
So
that is beyond my scope.
And probably beyond mine too. I mean, this gets into the deeper science of statin therapy. There's the smaller particles of lipoprotein A, and these things. I would really refer that question to a cardiologist.
Absolutely. Yeah. Okay. We will move on to our AFib question here. All right, this person says, I was diagnosed with AFib 3 years ago, and recently I went into atrial flutter. Are at-home monitors reliable? Are smartwatches with AFib monitors reliable? My at-home monitor says I'm in NSR now.
Yeah, they're very reliable. They're very reliable in being able to determine normal sinus rhythm, which is what when she said NSR. Atrial fibrillation, and probably atrial flutter. I'm really glad to hear that she's in normal sinus rhythm, because I thought the question was going, what do I do now about atrial flutter? Because atrial flutter is usually much harder to treat with medications but they do have flutter ablation and so on. But I'm glad to hear that she's in normal sinus rhythm. No, these watches are good, and they have for your phone where you can get a real EKG. They're remarkably clear.
All right. Well, that's great news. Okay. Next question here, Dr. Kumar, we will turn to you. Can you talk a little bit about ocular or eye signs and symptoms that may indicate vascular disease?
Yes, it's not very common, but when you go to the eye doctor, they look in the back of your eye. They're looking at the blood vessels to see how healthy your retina is. And inside the retina, you have blood vessels. And when you have carotid artery disease, if you have, this is especially true with soft plaques, essentially the plaque builds up in the base of the carotid artery that goes up to the brain. And the first branch in the brain that the carotid artery gives off is the artery to the eyeball, the ophthalmic artery. And if you have a soft plaque here, or what we call a friable plaque, ulcerated plaques also that can develop in the carotid arteries, little tiny microemboli can break off, and these are cholesterol emboli. Emboli meaning something that shoots out into an artery. So this emboli, or this little clot, shoots out and goes up to the eyeball artery, and it clogs it. You have other arteries or other branches there that feed the eyeball. So sometimes it causes a temporary blindness that lasts, it could last, 10 minutes or an hour, and then it returns, the eyesight returns. But when the ophthalmologist looks at the retina, they'll see that there's a little blockage there, that there's a little cholesterol plaque inside the artery. And that's usually, a red flag that you immediately have to get your carotids checked. And the first step is getting an ultrasound. Actually, the first step is call your primary.
Going back to our theme, call your primary. Okay. I know that we're nearing the end of time here, so let's take one final live question, and then I have just one question to wrap up the evening. So for our last question this evening, I know we were talking a little bit earlier about second opinions. So this person is wondering, can you talk a little bit more about that? Is it typical for a patient to have a test performed again if they were to come to you for a second opinion?
Well, second opinions are critical. At the end of every consult, I offer a second opinion to my patients. And quite frankly, if you're in a doctor's office and you ask for a second opinion and the doctor doesn't like that or gets upset, then you're in the wrong office. And we at Jefferson, of course, accept patients for second opinions all the time. We obviously, there's a time limit, so we want to get them in right away. In my own practice, I started Wednesday evening office hours just to be able to get patients in, because what happens is, a lot of times their children want to be with them for these second opinions, and by doing evening hours, they don't have to give up their work because the children are working or what have you. As far as getting the studies, it's sometimes a challenge, but once the patient requests a second opinion, they just have to sign a release, and then our office will call that doctor's office. And this happens all the time. Doctors usually or graciously will send the medical records. The x-rays typically are done on discs, and they have to be sent, but there's more and more online viewing of these studies. Certainly if it's within our system, we can look at the studies, and that does happen sometimes. My partner will say, hey, can you look at this patient wants a second opinion? You don't necessarily need to go out of Jefferson. We have thousands of excellent doctors. And so, it's still a second opinion just to hear somebody else's opinion on it. So second opinions are very important. And the other part of that is, what questions do you want to ask a doctor, particularly a surgeon? I would think Dr. Kumar will agree with this. And one of the questions you want to ask is, well, how many of these have you done? And what have your outcomes been? Now, much of this is publicly reported these days, particularly in cardiac surgery, but these are good questions. And the doctor should be able to tell you honestly how many and what their outcomes are and what kind of potential complications. So again, the patients really need to take ownership of their health, get the second opinion, and ask the difficult questions. And again, if the doctor doesn't like the question, you might want to consider a third opinion or go back to the original one. But most of us appreciate when there's an educated patient and asking really salient questions.
Yeah, I agree 100%. There's no harm. It's only benefit if you get a second opinion. And we have the same process in our office as well. Getting studies, it's very rare that I would have to repeat the studies unless there's something that I feel was overlooked. Then I would say, yeah, let's repeat the study. But overall, we're able to get records, and I have access, like web access, to a lot of the radiology sites in the region. So, I can easily jump on the computer, log into their website, and look at images and studies.
So again, just advocating for yourself. So a nice final question from our live audience. So thank you so much. And to close out this evening, I just have one final question for you both. And that is, what are your goals for everyone listening in on this webinar? What do you want our viewers to take away from tonight? And Dr. Kumar, I will go ahead and start with you.
I think one thing to remember is prevention is key. When we see, because we're surgeons, we see a lot of advanced vascular disease, and Dr. Singer sees advanced coronary disease, and that's why he's performing bypass surgery for them. So prevention is key. If you want to avoid having complex surgeries or get into the game of, procedure after procedure, taking good care of yourself, exercise, diet, following the recommendations of your PCP. If something doesn't feel right to you, getting attention. I would say that's the take-home message.
Okay, well, thank you so much. And Dr. Singer?
Yes, I agree with all of that. And, I have to go back to my 3 E's, eating, exercise, and motion. Let's not make this too complicated. Okay, some of us are dealt bad cards. We can't pick our parents. That's true. But our genetics go back thousands of years. So just because your parents have something, maybe your grandparents did not, and so you get lucky with those genes. But no matter what cards you're dealt with, you need to think about what you're eating. Personally, I think it should be spread out over 6 smaller meals a day, as opposed to, eating all at once, as I said, at night. Exercise some way every day, and, pay attention to your mental health. And that includes getting more sleep, drinking more water. I mean, I got bottles of this here, as a surgeon. I don't drink enough water. And in all that, the totality of it is the advocacy that we talked about earlier. Don't hesitate. Don't be afraid of going to the doctors. Don't think that you can tough it out. And don't do silly things, meaning like, don't smoke, as Dr. Kumar emphasized strongly. Don't go crazy on the highways. I tell you, it seems worse and worse anymore. We see people driving. We have to start taking care of ourselves, and taking care of ourselves will help take care of others.
Absolutely. The 3 E's, I will keep that in mind. Well, thank you so much, Dr. Kumar, and thank you, Dr. Singer, for your time this evening. Such great information was shared, and thank you to all our audience members for submitting such great questions. I know I learned a ton this evening, and I hope you did as well. Well, we will be posting an event survey, so you can let us know your thoughts, any other specialties you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, you can fill out the last question in the event survey. Be sure to visit jeffersonhealth.org to make an appointment. Stay up to date on upcoming events and webinars, just like this one and more. Be sure to also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to robotic surgery to planning for pregnancy and much more. A recording of this event will also be sent to you next week, so you can rewatch at your convenience. And if there's anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining us, and please be sure to stay safe and healthy. Have a great night. Thank you.